Welcome to the Deep Dive. Today, we are taking a massive plunge into a subject that is, well, it's foundational, it's clinical, and it's profoundly human: the comprehensive management of pain.
That's right.
Our source material isn't just theory, it is the absolute cornerstone of clinical practice, a critical, densely packed chapter from Brunner and Sutter's textbook of medical surgical nursing, 15th edition.
And for anyone listening who's aspiring to clinical mastery or, just needs a really swift expert level refresh, this material is non-negotiable.
Absolutely.
Pain management is so complex, it crosses pharmacodynamics, neurology, patient safety. Our mission today is to just break this entire clinical chapter down step by step.
And we're going to cover everything.
Everything. From the basic science of how pain works to the crucial assessment tools for verbal and nonverbal patients, and the specific multimodal pharmacologic and non-pharmacologic interventions that really define quality care.
So think of this as your shortcut.
Exactly. Your shortcut to understanding the entire system, exactly as a high-level nursing expert would approach it.
Okay, let's unpack this. We're starting right at the beginning because for clinical care, we have to define exactly what it is we're trying to manage.
And the definition is everything.
So these fundamental concepts of pain, let's start with defining it. How do we get a standard definition?
Well, you have the formal definition from groups like the American Pain Society. They'll say pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And that's medically descriptive, but it's not the standard we actually use in practice.
Right, this is where the clinical definition just completely trumps the academic one. It's all about the patient's reality.
Precisely. The bedrock principle, set forth so famously by Margot McCaffrey back in 1968, remains the undisputed clinical standard. And it is. Pain is whatever the experiencing person says it is, existing whenever he says it does.
And that's not just a nice idea.
No, it's not a philosophical statement. It is a binding directive. It means that the patient's self-report is the single most reliable indicator of pain we have, period.
As the clinician.
You, as the clinician, must accept that report and proceed with assessment and treatment. You cannot ethically or safely dismiss what a patient is telling you.
So if the patient says their pain is a 9 out of 10, even if they're, sitting there watching TV or look comfortable, we proceed as though it is a 9. That is the non-negotiable starting point.
Absolutely.
But why is it such a high-stakes emergency to manage that 9 out of 10 pain? I mean, why can't the patient just tough it out while the surgical wound heals?
This is such a critical point. It's what elevates pain management beyond mere comfort. Unrelieved pain is a profound physiological stressor. It unleashes this cascade of negative consequences across virtually every major body system.
So when you look at the systemic responses, like in a clinical guide or textbook table,
Yeah.
it's pretty alarming.
It is. Let's start with the immediate internal reaction. You asked what this stress does to the endocrine and metabolic systems. It throws them into total chaos. Unrelieved pain triggers a massive release of stress hormones: ACTH, cortisol, epinephrine, norepinephrine.
The whole sympathetic nervous system just lights up.
It lights up, and these hormones flood the body, leading to increased gluconeogenesis. Basically, the result is rapid hyperglycemia and muscle protein catabolism.
So the body is literally breaking itself down for fuel.
In a stressful, inflammatory state.
Yes.
And this significantly impedes recovery.
That explains why patients in severe pain so often have high blood sugars, even if they aren't diabetic. Now, what about the cardiorespiratory systems? I mean, these are life support. What are the major risks here?
They suffer greatly. On the cardiovascular side, you see increased heart rate, increased systemic vascular resistance, and a much higher cardiac workload.
Which means hypertension.
Right. And for any patient with pre-existing heart disease, this is extremely dangerous. On top of that, the pain-induced stress response causes hypercoagulation, which dramatically increases the risk of forming deep vein thrombosis, or DVTs.
And then, of course, pulmonary embolism.
Exactly. And the respiratory system is inhibited, right? Just like you said, patients avoid deep breaths because of the pain.
It just hurts to breathe.
It hurts to breathe. So you get decreased respiratory flows and volumes. Patients breathe shallowly and rapidly, and that leads to alveolar collapse or atelectasis.
Which means less gas exchange.
Right. It leads to hypoxemia, poor oxygenation, and the inability to cough effectively also just skyrockets the risk of pneumonia and other respiratory infections.
So poor pain control doesn't just feel bad. It actively contributes to DVT, pneumonia, and cardiac strain. What about the long-term impacts?
Well, beyond the acute physical insults like decreased GI motility, risk of ileus, urinary retention, there are profound consequences for the nervous system.
So it actually rewires things.
It can. Patients who experience severe acute pain are at an increased risk of developing chronic pain syndromes, sometimes called maladaptive pain. We're talking about things like phantom limb pain, post-thoracotomy pain.
His quality of life just plummets.
Completely. Chronically, unrelenting pain leads to severe decrements in quality of life. It increases anxiety, fear, sleeplessness, hopelessness. It's a vicious cycle that demands proactive, expert intervention.
So understanding these systemic dangers forces us to treat it effectively. But that starts with proper categorization. The textbook first breaks pain down by duration.
Right. We categorize by duration into acute pain and chronic or persistent pain. Acute pain is short-lived, hours to days, and it resolves as the tissue damage heals. It serves a protective function. It's the warning signal.
And chronic pain is different.
Chronic pain persists beyond the expected healing time. We often define it as 3 to 6 months, or simply lasting longer than the usual course of a disease.
But chronic pain isn't always constant, right? People have flares.
That's a key clinical point. Chronic pain, whether it's cancer or non-cancer related, like, say, diabetic neuropathy, often presents with a sort of underlying continuous pain level, but then has these intermittent, transient increases in intensity.
And that's what we call breakthrough pain.
Exactly, breakthrough pain or BTP. And it requires different, usually rapid onset management strategies than the background pain.
Okay, so the second, and I'd argue most important, categorization is by pathology, because this dictates the entire treatment regimen. This is the crucial split. The nociceptive or physiologic pain versus neuropathic or pathophysiologic pain. Nociceptive pain is the expected normal response to tissue injury. The sensory nervous system is working correctly to signal damage.
And this is the kind of pain that responds to the usual suspects.
Yes, this is the type of pain that responds well to traditional analgesics, opioids, nonopioids, and local anesthetics.
And nociceptive pain is further divided based on where the damaged tissue is.
Correct. You have somatic pain, which arises from structural tissues like bone, joint, muscle, skin. It's usually well localized and described as aching, throbbing, or pressure. Think classic post-surgical or fracture pain.
And the other type.
Visceral pain. This originates from internal organs, the viscera like the GI tract or pancreas.
Yeah.
This is often poorly localized and described as deep squeezing, cramping. Think of pain from an intestinal obstruction. And then we have neuropathic pain, the pathological pain that tells you something is wrong with the signaling system itself.
Neuropathic pain is abnormal. It is the result of a lesion or dysfunction within the somatosensory nervous system, either peripheral or central. Because the nerve itself is injured, the pain signals are generated and processed aberrantly.
Which is why the standard analgesics don't work as well.
Precisely why. Standard opioid analgesics are often ineffective or less effective. You need co-analgesic agents, antidepressants, anticonvulsants to stabilize those hyperactive nerves.
Can you break down the subcategories of neuropathic pain? Where does the dysfunction start?
It can be centrally generated, meaning the injury is within the central nervous system itself. So, for example, pain following a stroke or phantom limb pain, where the CNS pathways related to the limb remain active.
Or it can start out in the periphery.
Right. It can be peripherally generated, arising from injury to peripheral nerves. Think of the shooting, burning pain of diabetic neuropathy or nerve root compression radiculopathy.
And in the real world, it's often a mix.
The clinical reality is that many conditions involve components of both. We call that mixed pain. Fibromyalgia is a classic example. These patients require highly integrated, multidisciplinary management, using agents that target both tissue inflammation and nerve dysfunction.
So identifying the primary driver is the first step.
It's the first and most important step towards successful multimodal treatment.
Okay, this is where we shift from categorization to really understanding the hardware. To treat pain, we have to know the physiology of how the body generates the signal. The textbook outlines 4 key processes of nociception.
Right. We're tracking the signal from the injury site all the way up to the brain. Transduction, transmission, perception, and modulation.
Let's start with transduction.
So number 1, transduction is the conversion. When a mechanical, thermal, or chemical noxious stimulus hits tissue, it causes cellular damage, and that damage activates specialized sensory nerve endings called nociceptors.
What are the chemical players in that initial alarm stage? What gets released?
Damage leads to the immediate release of a whole soup of inflammatory mediators and excitatory compounds, serotonin, bradykinin, histamine, substance P. But the most clinically relevant group, especially for pharmacology, are the prostaglandins.
Prostaglandins are key because of their relationship to NSAIDs. Can you explain that mechanism in detail for us?
Absolutely. Prostaglandins are formed when the enzyme COX or cyclooxygenase acts on arachidonic acid released from damaged cell membranes. And what they do is locally sensitize the nociceptors, which initiates inflammation, swelling, and pain.
And here's the clinical link.
Here it is. NSAIDs are potent analgesics because they block that COX enzyme, thereby inhibiting prostaglandin formation right at the periphery.
And we know NSAIDs can be selective or non-selective for COX-1 and COX-2.
Exactly. COX-1 is sort of the housekeeping enzyme protecting your gastric mucosa. COX-2 is primarily induced by inflammation. So non-selective NSAIDs like ibuprofen inhibit both, which is why they have a higher risk of GI side effects.
But drugs like celecoxib are more targeted.
They are. COX-2 selective agents minimize that GI risk by sparing COX-1. And interestingly, acetaminophen acts primarily in the CNS to inhibit COX, which is why it relieves pain and fever but lacks that peripheral anti-inflammatory effect.
Okay, so once the signal is transduced, it moves into transmission.
Right. Number 2, transmission. This is the electrical action potential traveling along the afferent neurons up to the spinal cord's dorsal horn. And the speed and quality of the pain you feel depends on the fiber type.
What are the different fibers?
You have A-delta fibers, which are large, myelinated, fast conductors that signal sharp, immediate, well-localized pain. Then you have the small, unmyelinated C fibers. They're the slow conductors that signal that dull, aching, poorly localized second wave of pain.
And what happens when these fibers reach the dorsal horn, which is like the relay station in the spinal cord?
They release specific neurotransmitters into the synapse. A-delta fibers release glutamate. C fibers release substance P. Glutamate is crucial because it binds to the N-methyl D-aspartate, or NMDA, receptor.
And that NMDA receptor is a huge deal.
It's a huge deal. NMDA activation is a potent accelerator of pain transmission. It opens up ion channels and promotes the signal's continuation up the spinal cord. And that's why the NMDA receptor is such a hot target for newer or adjuvant analgesic agents like ketamine.
Okay, so from the spinal cord, the signal ascends to the brain, which leads us to number 3. Perception.
Right. Perception is the conscious cognitive experience. This is the result of all that neural activity reaching higher brain centers, resulting in the actual awareness of pain, along with all the associated emotional and behavioral responses, fear, anxiety, the impulse to pull away.
And this is where non-pharmacologic therapies come in.
Precisely. This is the specific stage where psychological and behavioral therapies like distraction, relaxation, imagery exert their effect. They work by changing how the brain processes or interprets that incoming neural signal.
And finally, the body's own built-in dampening system, modulation.
Modulation is the fourth process. This is where the nervous system tries to regulate or suppress the pain signal at every level, from the periphery to the cortex. You have these descending inhibitory pathways that release endogenous neurotransmitters into the dorsal horn.
And the main ones are?
Most notably, serotonin and norepinephrine. These chemicals act as the body's natural pain inhibitors.
Now we make the connection back to pharmacology, specifically to some of the antidepressants and dual mechanism drugs.
It's a perfect link. By preventing the reabsorption of these natural inhibitors, drug classes like SNRIs and TCAs prolong their presence in the synapse. They essentially amplify the body's natural ability to suppress pain transmission in the spinal cord. That's what makes them such powerful tools against chronic and neuropathic pain.
So the mechanism of nociceptive pain is a normal warning system. But neuropathic pain involves pathology dysfunction, hypersensitivity. Let's dive deeper into the 2 forms of sensitization.
Right. Neuropathic pain is driven by these maladaptive changes in the somatosensory system. First, you have peripheral sensitization. This happens locally, right at the site of the nerve injury.
What's changing at the injured nerve ending itself?
Well, the nerve injury causes changes in the ion channels, particularly the sodium channels. They become abnormally distributed, or you get an increased number of them at the injured site. This makes the nociceptor hyperexcitable. It lowers its threshold for firing.
So the nerve is basically on a hair trigger.
Exactly. It's sending pain signals with minimal provocation. And this leads to those defining paradoxical symptoms we see.
Allodynia and hyperalgesia.
Yes, the classic hallmarks. Allodynia is pain caused by a stimulus that is normally non-noxious. Imagine a light touch or just the friction of clothing causing severe pain.
And hyperalgesia.
Hyperalgesia is an exaggerated pain response to a stimulus that is noxious. The
Right.
pain is just far, far worse than you'd expect for the degree of injury.
And the situation gets even worse if that hyperexcitability moves inward to the spinal cord. That's central sensitization.
Central sensitization involves abnormal hyperexcitability of the central neurons in the dorsal horn. This is amplified by sustained injury signals, which results in extensive glutamate release. And that continuous activation of the NMDA receptor causes an influx of intracellular calcium, leading to prolonged firing and even structural changes.
So it's like a structural rewiring of the system.
It is. The central nervous system essentially gets stuck in a state of high alert, and it lowers the activation threshold for all the surrounding neurons. This is why central sensitization creates this vicious cycle of persistent, pathological pain that can spread beyond the initial injury site. It helps explain why some conditions are so clinically intractable.
Understanding the complexity of this science just reinforces why accurate assessment is so critical. This process has to be comprehensive and timely on admission with any new report of pain or any change in the patient's condition.
Right, and when you're interviewing a patient who can self-report, you have to use a structured approach. You need to capture the complete pain profile. You need the location where it hurts, have them point. The quality, is it sharp, shooting, aching, burning? That quality often hints at the pathology. Burning or shooting strongly suggests neuropathic involvement.
And the temporality, the timing of it all.
Onset and duration. Is it sudden or gradual? Constant or intermittent? You need to know aggravating and relieving factors, what makes it better or worse. And finally, the effect on function and quality of life. Is the patient unable to sleep or ambulate or interact with their family?
But the linchpin of the entire assessment is intensity. How do we reliably measure a subjective feeling?
We use validated, reliable tools. The most common is the Numeric Rating Scale, or NRS, usually a 0 to 10 scale. But we have alternatives for specific populations.
Like for kids or people with communication issues?
Exactly. For them, the Wong-Baker FACES pain rating scale is highly effective. It uses 6 cartoon faces to denote severity. There's also the FACES Pain Scale Revised, or FPSR, which uses a more neutral to grimacing photographic scale and a 0-10 metric. That one's often preferred for older adults and minority populations because of its cultural neutrality.
And the textbook explicitly details how to educate the patient on these scales. It's not enough just to hand them a sheet of paper.
That educational process is so crucial. You have to explain the scale that 10 is the worst imaginable pain. You have to discuss pain as a broad concept and acknowledge that any level, even a 3, is a problem if it interferes with function.
And this all ties back to the comfort function goal.
Yes. This is a modern, patient-centered necessity. The nurse must help the patient define the acceptable pain rating that allows them to perform essential recovery activities. For example, the goal isn't 0 pain. The goal is pain at a 4 out of 10 or less, so I can ambulate down the hall for physical therapy.
That ensures the treatment is actually aligned with safe functional recovery.
Preci-
So what happens when we lose that gold standard, the patient's self-report? Cognitively impaired, critically ill, sedated, or intubated patients are so vulnerable to undertreatment.
For these individuals, the clinical guidelines mandate the use of the hierarchy of pain measures, which is a structured 5-step framework designed to prevent us from overlooking pain.
Okay, walk us through those 5 steps.
Step 1 is always attempt self-report. You have to make every effort to get a report, even if it requires accommodations, larger font scales, a vertical orientation, simple yes-no signals like blinking.
And if that fails,
You move to step 2. Consider underlying pathology. If the patient has painful conditions, a fresh amputation, recent surgery, a fractured hip, you must assume pain is present and requires treatment.
okay, so step 3 is observation. What behaviors should the nurse be looking for?
Step 3. Observe behavioral signs. You look for facial expressions like grimacing or scowling, crying, restlessness, bracing, guarding. Many patients develop what's called a pain signature, a reproducible behavior when they're in distress.
But there's a huge safety alert here.
A critical one. The absence of behavior does not indicate the absence of pain. Sedation, paralysis, or just sheer fatigue can mask severe discomfort.
And the least reliable clinical indicator is step 4.
Step 4. Evaluate physiologic indicators. Vital signs, heart rate, blood pressure, respiratory rate are the least sensitive indicators. While pain initially causes them to go up, the body quickly adapts, and severe pain can be present even if vital signs have normalized. You cannot rely on a normal blood pressure to rule out pain.
So if you suspect pain after these 4 steps, what is the final definitive step?
Step 5 is to conduct an analgesic trial. This is both diagnostic and therapeutic. You administer a low, safe dose of an opioid or non-opioid, and then you carefully observe the patient's response. If their behavioral or physiologic indicators improve, you can titrate up.
And to make that observation more objective, the text highlights some validated tools specific to different patient populations.
Right. These structured tools formalize the behavioral assessment. The FLACC scale face, legs, activity cry consolability is used for young children. For nonverbal adults with advanced dementia, the Pain 80 scale is essential. And for the critically ill, intubated patient in the ICU, you'd use the CPOT, or Critical Care Pain Observation Tool.
Now, assessment isn't static, it's a continuous loop. How often must the nurse formally reassess pain and the treatment's efficacy?
Reassessment is mandatory, and it's always timed to the peak effect of the medication. This ensures we evaluate both effectiveness and safety. Generally, you're going to reassess 15 to 30 minutes after a parenteral dose, so 5E, IM, or subcutaneous, and about 1 to 2 hours after an oral dose.
And in a fast-paced setting like a PACU.
Right. In a post-anesthesia care unit during IV titration, reassessment might be required as frequently as every 10 minutes until the patient is stable and meets their comfort function goal.
We should also acknowledge specific population data. The source material draws attention to veterans and the unique pain challenges they face.
This is a crucial assessment point for any clinician. Younger male veterans from recent conflicts report significantly higher levels of severe pain and pain disorders, chronic low back pain, arthritis, fibromyalgia, often intertwined with PTSD or other mental health issues.
So you have to ask about military service.
You must specifically assess for military service. This complexity means simple medication regimens are often not enough. The nursing role becomes one of advocating for multimodal, multidisciplinary approaches, combining pharmacological agents with behavioral therapies, sometimes even complementary therapies like yoga, which has shown to reduce pain in this population.
All right, this brings us to pain management itself. The guiding principle of modern management is simple but profound. Multimodal analgesia.
It is now the unequivocal standard of care. It means using a combination of pharmacologic and non-pharmacologic interventions that work via different mechanisms of action at the same time.
So an example would be?
An NSAID, which is a peripheral COX inhibitor, plus an opioid, which is a CNS mu agonist, plus something like distraction, which works on modulation.
And what's the primary clinical benefit of this combination approach?
The goal is twofold: superior analgesia and enhanced safety. By attacking the pain pathway at multiple points, we can achieve better pain relief while using lower doses of each individual agent. This is known as the opioid dose-sparing effect.
Which is huge for safety.
It's huge. It significantly lowers the risk of opioid-related adverse effects, like respiratory depression and profound sedation.
Okay, let's talk about the delivery route. The route dictates onset, duration, and patient convenience. Let's review the key ones.
The oral route is always the preferred standard. It's the most cost-effective, best tolerated, and easiest for the patient to manage long-term.
But in the acute setting?
In the acute setting, parenteral routes, ORGU or subcutaneous, are often necessary for immediate relief. 4 is first-line post-surgery, and then you transition to oral as soon as gastric function allows.
What about rectal, topical, and transdermal routes?
The rectal route is an alternative, often used in palliative care. But it's strictly contraindicated in neutropenic or thrombocytopenic patients because of the high risk of bleeding.
And it's important to distinguish between topical and transdermal.
Very important. Topical agents like the diclofenac gel work locally, producing effects only immediately under the application site. It's targeted peripheral analgesia. Transdermal delivery, like the fentanyl patch, requires systemic absorption to achieve its central effects.
And that systemic absorption rate for transdermal patches has a major clinical implication, especially for patient teaching.
An absolutely critical point. Because the fentanyl patch has to diffuse into the systemic circulation, it takes 12 to 18 hours to achieve a therapeutic effect. Therefore, it is not used for acute pain.
And there's a big safety alert about heat.
A huge one. Any application of heat, a heating pad, a hot tub, even a fever, can dramatically and dangerously increase the absorption rate, leading to a rapid overdose and respiratory depression.
Okay, for the most intense pain, we rely on regional techniques. Describe the difference between neuraxial and continuous peripheral nerve blocks for us.
Neuraxial analgesia is the delivery of medication into the epidural or intrathecal space, directly impacting the spinal cord's relay station. We commonly use a combination of an opioid, like fentanyl, and a local anesthetic, like ropivacaine.
So you get that multimodal effect right at the source.
The most potent one, yes. And a continuous peripheral nerve block offers even more localized targeting. It involves placing a fine catheter next to a targeted peripheral nerve group and continuously infusing a local anesthetic.
And the benefit of that.
The beauty of it is that the dose can often be kept low enough that it primarily blocks the smaller sensory fibers responsible for pain while sparing the larger motor fibers. So the patient can maintain motor function and participate in physical therapy.
Now, whether the patient is using IV or oral meds, we need to choose the appropriate timing regimen.
Right. For any pain that's present, 12 hours or more a day continuous pain, the standard is around the clock, or ATC, scheduled dosing. This maintains stable blood levels and prevents those debilitating pain flares.
And PRN.
PRN, or as-needed dosing, is reserved for intermittent pain, pre-procedure doses, or, most commonly, for managing that breakthrough pain we talked about. But the goal of titration, whether ATC or PRN, is always that comfort function goal.
Okay, let's talk about patient-controlled analgesia, or PCA. It's a key method for empowering patients in the acute setting. How does it work?
PCA allows patients to self-administer small, frequent doses of analgesic agents. The PCA dose at preset intervals, which are controlled by a locked-out time limit.
What's the primary prerequisite?
The fundamental prerequisite is that the patient must be cognitively and physically able to understand and operate the device. They have to recognize their pain, know how to push the button, and understand the relief that follows.
Let's discuss the controversy surrounding the basal rate.
The basal rate, or continuous background infusion, is a major safety concern. It is generally discouraged for opioid-naive patients because that continuous infusion, combined with patient-administered boluses, significantly increases the risk of drug accumulation and profound sedation and respiratory depression.
So it's usually reserved for specific cases.
Only for patients who are already opioid tolerant or for certain modalities like patient-controlled epidural analgesia.
And the most important safety alert related to PCA involves who is allowed to push the button.
This is the absolute rule. PCA by proxy is strictly prohibited. Only the patient who is prescribed the device is allowed to activate it. Unauthorized activation by anyone else can lead to dangerous dose stacking because they can't accurately gauge the patient's level of pain or, more importantly, their level of sedation.
So if a family member thinks the patient is in pain,
they must notify the nurse, who will assess the patient and administer a prescribed dose if it's appropriate.
Okay, we're now moving into the specifics of the drug groups, starting with the nonopioids, which really form the bedrock of multimodal therapy.
They're absolutely crucial. Nonopioids, acetaminophen, and NSAIDs are first line for mild to moderate nociceptive pain and are an essential component for severe pain because they provide that vital opioid dose-sparing effect.
And you can give them together.
You can and you should because their mechanisms are different.
So starting with acetaminophen, or Tylenol, what is its mechanism and the primary safety risk?
It works centrally to inhibit COX, reducing pain and fever. It's generally well tolerated. The major safety risk, however, is hepatotoxicity, liver damage from overdose.
And the max daily dose is a bit of a moving target.
It is. While it's often cited as 4,000 milligrams in healthy adults, many guidelines now recommend limiting it to 3,000 milligrams to mitigate risk, especially when it's combined in other products. And you have to caution patients about concurrent alcohol use.
Now, to NSAIDs, ibuprofen, naproxen, celecoxib, these carry more numerous systemic risks.
They do. They inhibit peripheral prostaglandin synthesis via COX-1 and COX-2 inhibition. The most common adverse effect is gastric toxicity and ulceration. And this is a systemic effect. It doesn't matter if it's oral or IV because it's due mainly to the inhibition of COX-1, which reduces the protective prostaglandin layer in the GI mucosa.
Who is most at risk for this serious GI side effect?
Risk factors include being over 60, a prior history of ulcers, and concurrent steroid use. Management often involves switching to a COX-2 selective NSAID, like celecoxib, which spares that protective QX1, or co-administering the NSAA with a proton pump inhibitor, a PPI.
And the other major systemic risks involve the heart and the kidneys.
Right. All NSAIDs carry a cardiovascular risk by altering prostaglandin synthesis, which can increase the risk of thrombotic events. This risk is highest during the first month of treatment. You have to use the lowest effective dose for the shortest possible duration.
And renal toxicity.
Renal toxicity is the third major risk. NSAIDs reduce renal prostaglandin formation. This is particularly dangerous in patients who are dehydrated or hypotensive, as those patients rely on those prostaglandins to maintain adequate renal blood flow. So hydration is key.
Okay, shifting to the most powerful class, the opioids. We should reinforce the terminology here. Opioid analgesics. Let's clarify the differences between the three main opioid groups.
The first-line agents are the mu agonists, morphine, hydromorphone, and fentanyl. They produce analgesia with no ceiling effect, meaning the dose can be continually increased until you're limited only by the onset of adverse effects.
And what about the group that carries a major clinical warning for patients already on opioid therapy?
Those are the agonist-antagonists, or mixed agents, like nalbuphine. They're kappa agonists, but weak mu antagonists. So if you give these to a patient who is physically dependent on a mu agonist, you can precipitate immediate, severe opioid withdrawal and rebound pain. They should be avoided entirely in those patients.
And the third group is the antagonists.
Like naloxone, which displace the opioid from the receptor to reverse respiratory depression.
Before we discuss specific drugs, let's get the core terminology straight, because confusion here leads to poor treatment and stigma. We need to distinguish between physical dependence, tolerance, and substance use disorder.
This is so vital for safety and for patient communication. Physical dependence is a normal, expected physiologic adaptation that occurs after 2 or more weeks of continuous opioid exposure. If you stop the drug abruptly, the patient will experience withdrawal. It's not a choice, it's the body adjusting.
And how is that different from tolerance?
Tolerance is also a normal physiologic process. It's where the analgesic effect of a previous dose diminishes, requiring a higher dose to get the same relief. Tolerance develops to most adverse effects like sedation and nausea, but critically, it rarely develops to opioid-induced constipation.
And the key psychological component is substance use disorder, or SUD.
SUD, formerly known as addiction, is a chronic disease characterized by craving, compulsive use, and impaired control despite harmful consequences. It's independent of pain relief and is influenced by genetic and psychosocial factors.
And we have to talk about pseudo-addiction.
Yes, the textbook stresses the concept of pseudo-addiction, demanding or drug-seeking behaviors that are actually caused by unrelieved pain. When the pain is finally adequately managed, these demanding behaviors vanish.
Then there's the paradoxical condition, opioid-induced hyperalgesia, or OIH.
OIH is the opposite of tolerance. It's a paradoxical state where increasing doses of an opioid actually increase the patient's sensitivity to pain. It lowers their pain threshold.
What's the thinking behind that?
It's thought to involve central and peripheral nervous system changes, including excessive NMDA activation. Clinically, if you are continuously escalating the opioid dose and the patient reports their pain is getting worse, you have to suspect OIH.
Since patients are frequently switched between different opioids or different routes, we need a precise guide. This is where equianalgesia comes in.
Equianalgesia is a critical clinical skill, essential for safety. The equianalgesia tables provide guidelines for converting between different opioid drugs and routes based on their relative potency, ensuring you prevent over- or underdosing.
So you can't just switch one to one.
No, for instance, oral morphine is metabolized differently than IV morphine, requiring a conversion ratio. If a patient is stable on IV morphine and needs to switch to oral hydromorphone, you must use the table to calculate the appropriate starting dose. Ignoring these ratios is one of the fastest ways to cause respiratory depression or uncontrolled pain.
Let's focus on the first-line MUVD agonists, starting with the standard, morphine.
Morphine is the prototype. It's relatively hydrophilic, so it has a slower onset but a longer duration. The major caution, especially in patients with renal failure, is its metabolites, M3G and M6G.
What do they do?
M3G is neurotoxic and can accumulate, causing myoclonus, delirium, and seizures. This accumulation often necessitates what we call opioid rotation, switching to a drug like fentanyl that doesn't have these active neurotoxic metabolites.
And fentanyl is the opposite in many ways.
It is. Fentanyl is highly lipophilic, rapid onset, short duration. This makes it ideal for immediate, severe, acute pain or in patients who are hemodynamically unstable. And crucially, it doesn't produce clinically relevant active metabolites, making it safer for patients with kidney dysfunction.
What about hydromorphone?
Hydromorphone, or diluted, has intermediate lipophilicity. It's a common choice for PCA. It's a powerful alternative to morphine.
Now, which opioids are strictly contraindicated or avoided?
Codeine is a prodrug that needs the CYP2D6 enzyme to convert to active morphine. Since about 5 to 10% of the population lacks this enzyme, it's often ineffective. Most importantly, meperidine or Demerol should be strictly avoided.
Why is that?
Its long-lasting metabolite, normeperidine, is a CNS stimulant that causes irreversible neurotoxicity, leading to severe tremors, delirium, and generalized seizures. Its use is severely restricted.
And finally, we have the dual mechanism agents that are like multimodal analgesia in a single pill.
Right, tramadol and tapentadol. They're synthetic opioids that provide weak mu opioid binding, plus they block the reuptake of serotonin and norepinephrine.
What was the difference between them?
Tramadol blocks both S and NE reuptake, but this lowers the seizure threshold and creates a significant risk of serotonin syndrome when combined with SSRIs. Tapentadol blocks only NE reuptake. It has a more favorable GI profile and is generally preferred due to its lower risk of complex drug interactions.
This brings us to the most serious patient safety topic in pharmacology: managing opioid adverse effects. We have to dedicate time to constipation and the POSS scale.
We must. Since tolerance rarely develops to opioid-induced constipation, a preventive approach is mandatory for the entire duration of therapy. This means nurses must institute a daily bowel regimen combining a stool softener and a mild peristaltic stimulant. Waiting until the patient is constipated is a failure.
Okay, let's move to the most serious adverse effect: sedation and respiratory depression. We know the principle. Excessive sedation precedes respiratory depression. How is this monitored clinically?
This is where expert clinical judgment and protocol adherence are absolutely vital. We use the Pasero Opioid-Induced Sedation Scale, or POSS. This is not optional. It's a mandated monitoring tool because it assesses the earliest sign of risk, sedation.
Describe the critical levels of the POSS scale and the mandatory nursing interventions.
Levels S, 1, and 2 are acceptable. The patient is easily aroused or awake. Level 3 is the red flag. It's the unacceptable level. The patient is frequently drowsy, drifting off during conversation. At level 3, the nurse must monitor the patient closely, ask them to take deep breaths, and most importantly, decrease the opioid dose by 25% to 50%.
And if the patient progresses to level 4?
Level 4 is a medical emergency. Unacceptable. The patient is somnolent with minimal or no response. The nurse must stop the opioid immediately, call the rapid response team or a code blue, and prepare to administer naloxone.
And you have to be careful with naloxone.
You have to titrate it slowly, often diluted, to reverse the respiratory depression without causing a rapid, complete opioid reversal, which can trigger severe, abrupt pain and adverse cardiovascular events.
Why must the nurse look beyond just the respiratory rate number?
Because a respiratory rate may be deceptively normal, but the depths could be shallow. You must also listen for snoring, which is a sign of upper airway obstruction. And for high-risk patients on supplemental oxygen, standard pulse oximetry can mask hypoventilation. In those cases, capnography monitoring end-tidal CO2 is often recommended to accurately reflect ventilation.
Okay, the third group of agents, co-analgesics or adjuvants, are essential, especially for treating neuropathic pain, and their dosing regimen is distinct.
They're initiated at low doses and titrated very slowly, often taking weeks or months to achieve their full analgesic effect. They're typically inappropriate for acute pain, but indispensable for chronic or neuropathic pain.
Starting with local anesthetics, how are they used?
They're sodium channel blockers. The most common topical use is the lidocaine patch 5% for localized neuropathic pain, like postoperative neuralgia. The dosing is often 12 hours on and 12 hours off to minimize systemic absorption. Nurses must monitor for systemic toxicity, though it's rare, which presents first as CNS signs, a metallic taste, tinnitus, or irritability.
And the anticonvulsants have become first line for neuropathic pain.
Yes, the membrane stabilizer anticonvulsants, gabapentin and pregabalin. They work by modulating calcium channels, reducing neuronal excitability. They're crucial for diabetic neuropathy and are increasingly used pre- and post-operatively to prevent persistent neuropathic pain syndromes.
Finally, the antidepressants, utilizing that modulation pathway we talked about earlier.
We use two main classes. TCAs, or tricyclic antidepressants like nortriptyline, were traditionally first line but carry a high burden of adverse effects, including dry mouth, orthostatic hypotension, and cardiotoxicity. The preferred modern alternative is the SNRI serotonin and norepinephrine reuptake inhibitors like duloxetine and venlafaxine. They're equally effective but have significantly better tolerability.
The last specialized agent is ketamine, the NMDA antagonist. Why is it used?
Ketamine is a powerful agent that blocks that hyperactivating NMDA receptor. It's used for refractory acute pain or in patients with profound opioid tolerance. Its massive advantage is that at analgesic doses, it is a dissociative anesthetic that does not cause respiratory depression, unlike opioids.
Moving on to special populations.
Yeah.
Older adults are often highly sensitive to all these agents. How must the nurse modify management?
The guiding principle is universally start low, go slow. Older adults, especially those over 70, are profoundly sensitive to the CNS effects, sedation, dizziness, confusion. The clinical guideline recommends reducing the opioid starting dose by 25% to 50% for adults over 70.
And considering their increased risk for NSAID-related complications.
Acetaminophen is recommended as the first-line nonopioid for musculoskeletal conditions like osteoarthritis. If an NSAID is necessary, topical formulations are preferred for localized relief to minimize systemic absorption.
We have to address an ethical and clinical practice standard that must be absolute: the use of placebos.
There should be zero ambiguity here. A placebo is a sham treatment. Placebos must never be used clinically in a deceitful manner to treat pain. They are only ethically appropriate in informed consent research settings.
And why is the deceptive use of a placebo so damaging to clinical care?
It violates the fundamental nurse-patient trust relationship. It's dishonest practice. And critically, if a patient reports pain relief after receiving a placebo, it does not invalidate their initial report of pain. The pain was real, and the patient has now been denied the necessary evidence-based assessment and treatment they require.
Okay, let's talk about non-pharmacologic methods. They aren't a replacement for medication in severe pain, but they are a mandatory component of multimodal therapy.
Absolutely. These methods can be used alone for mild to moderate pain, but their true strength is in their complementary role with medication for severe pain. They facilitate relaxation, reduce anxiety, and most powerfully, provide the patient with a crucial sense of control.
The source categorizes these into physical and cognitive modalities. Let's list some key examples.
Physical modalities include things like proper body alignment, therapeutic heat and cold, which require a prescription in many inpatient settings for safety massage, TES, and physical therapy. Cognitive and behavioral methods aim to influence perception and modulation, things like relaxation breathing, distraction, guided imagery, humor, and meditation.
What are the key nursing implications when integrating these into the care plan?
The nurse must ensure that the patient and family clearly understand these methods complement pharmacologic agents. They do not replace them. We need to be proactive and explore any patient fears about analgesics that might tempt them to rely solely on these methods when medication is clearly required for safe functional recovery. And of course, always respect their right to refuse.
This brings us to the culmination of our entire deep dive: structuring the acute pain care plan using the nursing process framework.
Right, the interventions just summarize our entire discussion. The foundation is laid by performing a comprehensive pain assessment and accepting the patient's report of pain as the undisputed standard.
The plan must then transition immediately to action and goals.
Yes, the nurse has to assist the patient in defining a comfort function goal, tying relief directly to functional outcomes. Then they must administer analgesic agents as prescribed, using the principles of multimodal analgesia.
And what about the ongoing safety loop?
The nurse must reassess pain relief and adverse effects at peak time. This is the evaluation of effectiveness and safety, specifically using tools like the POSS scale. They must proactively prevent and treat adverse effects, meaning immediate initiation of a bowel regimen, prompt dose reduction for sedation, and educating the patient and family to address their fears about dependence versus addiction.
So what defines successful expert pain management? What are the expected outcomes?
Success is achieved when the patient reports a pain intensity that allows them to participate in important functional activities like ambulating or eating. And, just as important, the patient tolerates all interventions without major adverse effects, particularly avoiding sedation and respiratory complications, and demonstrates a clear understanding of their treatment plan.
So we have completed a massive tour of pain management.
We have. We covered everything from the molecular triggers of transduction and the pathological changes of central sensitization right through to the critical clinical safeguards like interpreting equianalgesia tables and adhering to the Pasero Sedation Scale protocol.
And at the end of the day?
At the end of the day, remember, the core of expert nursing practice in pain is always respecting the patient's subjective report. The goal is always a safe, individualized, and powerfully multimodal approach that gets them to their comfort function goal.
Absolutely. We saw why understanding the difference between nociceptive and neuropathic pain dictates whether you reach for a mu agonist, a specialized anticonvulsant like gabapentin, or both. We hammered home the crucial distinction between tolerance, dependence, and SUD, which allows you to treat patients ethically and aggressively without stigma.
That's right.
For you, the aspiring or current clinician, the final thought is this. Knowing the danger of systemic harm and the reality of the opioid crisis, how do you ensure that you proactively integrate non-opioids, co-analgesics, and non-pharmacologic therapies right from the moment of admission, ensuring your patient achieves functional recovery without ever being forced to choose between crippling pain and the potentially lethal risk of respiratory compromise? That commitment to proactive, comprehensive, and safe multimodal care is what defines expert pain management in the 21st century.